Thank you. Good afternoon, everybody. So I think without further ado, it gives me great pleasure to introduce the first speaker of this session. And the overall theme of this session is on hepatitis elimination. This is part one. And part two comes a little later this afternoon, and focusing screening, testing, and monitoring. And so John Ward will be presenting on from pandemic response to pandemic recovery, opportunities for viral hepatitis elimination. John Ward will be well known to almost all of you. He directs the Coalition for the Global Hepatitis Elimination of the Task Force for Global Health, which is a community of practice providing technical assistance and monitoring progress towards hepatitis elimination, and really has done magnificent work over the last few years. And you will also know John from his time as director of the Viral Hepatitis Program at Centers for Disease Control. John,
thank you so much. Thanks, Philippa. Thanks, Mark. Good afternoon, everyone. It's great to be back at COLDA to see longtime colleagues and meet new colleagues today and through the weekend. Look forward to that. And I really appreciate the opportunity to discuss the relationship between the response to COVID-19 and our efforts to eliminate hepatitis. These are my disclosures. And what I'd like to talk about is just to, again, recognize the scope of the COVID-19 pandemic, the impact of the response to that pandemic on our efforts to deliver hepatitis prevention care and treatment services, give some examples of opportunities coming from the COVID response to build capacity for hepatitis elimination, the roles of hepatitis elimination programs in pandemic response, and then some of our activities at the Coalition, recognizing that we're moving from pandemic response to pandemic recovery to continue to monitor that relationship between COVID-19 response and hepatitis elimination, and then developing a white paper to help highlight that relationship as people begin to plan for preparedness and development of resilient health systems. So we have had a large pandemic. As you can see there, over 6.5 million deaths have been attributed to COVID-19 since the start of the pandemic in early 2020. The response to the pandemic and has had a negative impact on the delivery of a wide variety of medical services, including those for hepatitis prevention, care, and treatment. This is an example of the declines in immunization coverage for infant hepatitis B vaccination as part of pentavalent vaccination programs, where they really have had the largest decline in infant immunization coverage since records were kept, and the declines have been quite remarkable in some African countries, as shown on this slide. So this is an impact that has to be addressed, and there's a variety of mitigation strategies underway to seek to return those coverage levels back to pre-pandemic levels, and to plot out catch-up vaccination strategies for those missed over this pandemic period. There's also been impact on delivery of care and treatment. This is an example early in the pandemic, looking at hospitals in 3 African countries showing large declines in direct patient care in hepatitis clinics. Contributing factors include patient anxiety about coming into clinical care, social distancing measures, redirection of staff in clinic space for the COVID response, shortage of consumables with hepatitis medications as one example. So those adverse impacts, have to be recognized and dealt with. We did a global survey as part of the Coalition during the last 6 months of 2020, again with program managers and clinicians reporting large declines in the delivery of hepatitis testing and treatment services. But on a more positive note, as indicated by the green bars, when asked how was that trend over time, they were reporting that there was improvement in the number of persons being tested and treated in their facilities as these barriers and concerns were recognized, and strategies were put in place to deal with those. What I also found hopeful in that survey, when asked what were some of the positive benefits coming from the COVID-19 response, people began to report, well, laboratory testing has improved. There's better relationships between primary care providers and specialists, improved clinical training, and they demonstrated the value of hepatitis clinics in pandemic response. And I really seized on that as recognizing we're in the midst of a transformational moment in public health and clinical care brought upon us by this response to COVID-19. And how could it begin to address some of the gaps that we all know that we're having to deal with, such as the low percentage of people who know their status who are living with chronic hepatitis C and hepatitis B, and how could this response to COVID-19 begin to help us address some of these gaps? So that led us to have a side event at the United Nations General Assembly in 2020, where we brought together people from around the world to address this, ranging from the organization FIND to talk about diagnostic capacity building, Africa CDC, Ethiopia colleagues from Korea. And then the example of what was being provided as an example of capacity building was the remarkable response that put in place virologic detection platforms in national laboratories, so that the number of countries that had these platforms rose from only 2 at the start of the pandemic to, by August of 2020, all countries having those platforms in their national laboratories through the work of Africa CDC and other partners. There's also that's been part of a much larger global initiative that over a 2-year period raised almost $19 billion to support capacity building, in particular for diagnostic testing, that contributed to purchasing almost 176 million tests for COVID-19 in 180 countries, either in laboratory PCR testing or more antigen-based testing that could be done in clinics or even at home. Other benefits of strengthening capacity is shown on this slide: workforce training, supply chain improvements, etc. All of that can be applied to other disease states, as these assays are not restricted to COVID-19, but they are platforms for testing for other virologic agents, including hepatitis B virus and hepatitis C virus. So really, how can that capacity that's now out there be applied to what needs to be done for hepatitis? And there's 2 examples here. Example from Pakistan: because of this COVID response, they were able to move from manual PCR testing to automated machine-based testing. So that improved both throughput, the number of tests that could be performed, and the quality of that testing, either in laboratory or point of care with GeneXpert testing, really helping to support initiatives for hepatitis elimination. In Ethiopia, again, they began to have better access to automated PCR testing, opening the gateway to hepatitis testing, and making it no longer a requirement that specimens had to go out of the country for hepatitis testing, but that testing can actually be done more in country. And there are other examples, and hopefully in our Q&A and discussion section, I would be interested to hear your own local experiences. In turn, countries that had strong hepatitis programs demonstrate how those programs can help those countries more rapidly respond to a pandemic. I'm sure we're all very familiar with the remarkable hepatitis C elimination program in Egypt, where they have scaled up large-scale hepatitis testing. When the COVID epidemic began in Egypt, they had a limited availability of testing capacity for COVID, so they redirected the hepatitis testing program to become a COVID-19 testing program and begin to test millions of specimens thereafter. Similarly, Georgia, which also has a strong hepatitis C elimination program, with their testing beginning with their national laboratory and then progressively extending that out to be more centralized with laboratories throughout the country and clinic-based testing. Again, testing large volumes of persons in Georgia. When the COVID-19 pandemic arrived in Georgia, they again redirected that to COVID-19 testing, and just in the first 10 months tested over 1 million persons in a country of a little over 3 million people. So again, demonstrating how hepatitis programs can play a role in pandemic preparedness. And then there are other examples of COVID-19 bringing about other changes in care that can improve our care for hepatitis. Telehealth, interacting with patients either online or on mobile devices has been shown to be very effective. This just shows the huge increase in the United States, but there are other examples from other countries. Granted, there are limitations sometimes in web access or access to cellular networks, et cetera, but by and large, this is just another example of extending patient care outside of the clinic in a way that can improve access to that testing. Access to marginalized populations were improved. This is an example from Leeds, England, where previously homeless people were sheltered. And while they were sheltered, it was recognition it was a good opportunity to test and treat for hepatitis C. They found a high prevalence of hepatitis C, and they found high acceptance when hepatitis C treatment was offered for those persons who were HCV infected. There are also changes in harm reduction for people who inject drugs. I thought this was a recent report from South Africa, which by and large, access to syringe service programs and opioid substitution therapy is fairly limited in Africa, but there were some positive advances in that regard over the course of the COVID-19 epidemic response, with greater availability of what's called harm reduction services within shelters where high proportions were people who inject drugs. Looking at new options such as take-home opioid substitution therapy, better acceptance by law enforcement of the needs of people who inject drugs, so better, less stigmatization and criminalization in those areas, and then really opening up conversations about how to sustain access to these services over time. Still a long way to go, but opening up doors for progress in those areas while recognizing there's still limited access to treatment, which is a overarching barrier that has to be addressed. There's also multinational initiatives in response to COVID-19 in Africa for disease surveillance. Africa CDC has developed a regional integrated network bringing together national public health laboratories that have the workforce and technologies in place for virologic and other pathogen detection and surveillance. And then through that network, sharing that information so that emerging threats can be more quickly identified and detected throughout the region. There's a big move to improve vaccine production in Africa, recognizing there was long delays between vaccines being produced elsewhere and their availability in Africa. There's a big WHO technology transfer hub that's being developed here in South Africa with the idea of transferring that knowledge and know-how to other low and middle income countries in Africa and elsewhere. And then there's a move toward diagnostic production in Africa through the CDC Africa Partnership to accelerate COVID-19 testing. So many of those areas, even though hepatitis is not explicitly mentioned, they do, I believe, provide new avenues for improving hepatitis services. So here we are, we're sort of moving from pandemic response, to pandemic recovery and preparedness. So where do we go, from here is the real, question. And when you think about the COVID pandemic, you started with resources from the established health systems. You then brought in new resources to, and then that really sets up, your. The question is, proceed in that direction after a pandemic response, such as flu, the SARS epidemic of the early 2000s, go back to status quo. And in mind, a group of partners has brought together a financial preparedness and response. Several weeks ago, that there's about $1.4 billion for this fund. A set of priorities, and I'll give you some examples, so that you can overall to be able to detect and respond to the next pandemic threat. But there's also a recognition in this fund development that it needs to be also strengthening the responses to endemic threats, because that's really the only way you can truly prepare a health system for an unknown threat, is for it to be more able to detect and respond to endemic threats. And they give examples here in that, and they recognize that only by strengthening the response to endemic threats can you sustain the resources they feel like is needed for pandemic response. And there have been pilot initiatives in this regard to begin to demonstrate how you bring together the COVID response with other disease initiatives, such as the neglected tropical disease elimination programs and integrating COVID testing and vaccination in those programs, TB, malaria, and others that you see there, and influenza-like illness surveillance again. And you see the large number of African countries that are participating in those initiatives. What bothers me is that the hepatitis programs are not in that list. And I think that needs to change, as hopefully I've demonstrated that hepatitis programs can indeed have a role in pandemic preparedness. So we're going to move toward development, or we've just launched development of a white paper by the coalition to really make the case that hepatitis elimination is pandemic preparedness, by highlighting the synergies between the capacity needed for pandemic preparedness with that required to eliminate hepatitis, show examples how investments in the infrastructure for hepatitis elimination enhance preparedness and vice versa, and then make the case for funding to support hepatitis elimination builds resilient health systems responsive to endemic and emerging threats. So what we're in the progress of doing is conducting a literature review of the impact of COVID-19 on the delivery of hepatitis testing, care, and treatment, and reporting, and the new opportunities coming from the pandemic response. And I'm giving you some glimpse of that literature review over the course of this presentation. And they're going to develop case studies with key informants. I gave you sort of, again, a glimpse of that from our conversations with our colleagues in Ethiopia, Pakistan, Georgia, Egypt. We'd like to continue to collect those experiences to create a compelling case for the role of hepatitis programs in pandemic preparedness. We're bringing together a steering group of experts in sort of thinking through these priorities for pandemic preparedness at the global level or at the national level, as well as persons who are working to deliver hepatitis vaccination, care, and treatment services at the national level and local level. And we look forward to getting this out in the first quarter of 2023. So it really is an invitation for you to begin to share your experiences with us so we can bring together this group of compelling case studies of either the real or potential opportunities that are made possible by the COVID response for hepatitis, for improving hepatitis prevention, care, and treatment. And then we have a survey up on our website. Here's the link here. So we'd like to do, it's sort of a second version of the survey that I mentioned earlier. We just wanted to take account how has the impact of COVID-19 on hepatitis elimination changed over time, both the detrimental impact, but also these new opportunities that I've alluded to. And I would greatly appreciate all of you participating in that survey. So in conclusion, I think the COVID-19 recovery phase offers real opportunities to build capacity for elimination of hepatitis B and hepatitis C transmission and disease. I think it's important for us to continue to highlight that relationship, and that's the purpose of the survey. And I think that we went through the white paper, we looked to bring together the evidence and the case experiences to inform adoption of hepatitis services and plans for pandemic preparedness. And I thank you for your time and look forward to the discussion and questions.